5-minute medicine series on sepsis. The criteria for sepsis are 1. Known or suspected infection, but documented positive cultures are not required, and 2. Two or more criteria are met for the systemic inflammatory response syndrome, or SIRS, which are temperature greater than 38 degrees or less than 36 degrees, leukocyte count greater than 12 or less than 4, respiratory rate greater than 20 per minute, and heart rate greater than 90 per minute. The criteria for severe sepsis are evidence of sepsis-induced organ dysfunction, like hypoxemia, shock, delirium, thrombocytopenia, or a rising creatinine or bilirubin level. Severe sepsis can have very high mortality rates. Patients with 2 dysfunctional organ systems, or those that have received multiple liters of volume replacement but still require vasopressor support to maintain their mean arterial pressures at greater than 65 ml per mercury, can have mortality rates approaching 50%. Sepsis is a complex dysregulation of both inflammation and coagulation. Toxic microbial stimulus initiates a deleterious host inflammatory response, which induce endothelial damage. Endothelial damage leads to microaggregates of fibrin, platelets, neutrophils, and erythrocytes, which can impair capillary blood flow and decrease oxygen and nutrient delivery to tissues. It is important to note that not all infections result in sepsis. The reason to recognize and properly treat infections early on is to prevent sepsis from occurring. A thorough review of systems should be performed, trying to identify a potential site of infection that may guide management strategy. Ask about headache, neck stiffness, cough, chest pain, shortness of breath, sputum production, diarrhea, dysuria, frequency and urgency of urination, back pain, sore joints, new rashes, and any open sores or ulcerations. If the patient is recently post-operative, they may have an infected wound or internal abscess causing the sepsis. Also look for indwelling lines or catheters, as these frequently lead to infection. Diagnosis of sepsis rests on a thorough history if possible, physical examination, and appropriate laboratory findings, which allow detection of the previously mentioned features of SIRS. However, keep in mind that some signs, like fever, are sometimes blunted or absent in immunocompromised or older patients compared to those younger than age 65. Identifying and controlling the patient's source of sepsis is an essential part of the management. Laboratory investigations are tailored to those that help with the diagnosis of sepsis and those that help identify potential complications and sources of the sepsis. The kidneys and liver can become dysfunctional in sepsis. Elevated serum lactate is typically present in patients with severe sepsis or septic shock and may be secondary to anaerobic metabolism due to hypoperfusion. Obtaining serum lactate is essential to identifying tissue hypoperfusion in patients who are not yet hypotensive but who are at risk for septic shock. An arterial blood gas can help you assess a patient's ventilation status, which can be affected if a patient is in severe lactic acidosis. Obtain cultures of blood and other possible sources of infection. The Surviving Sepsis Campaign guidelines contain recommendations regarding the management of patients with severe sepsis and septic shock according to the strength of their supporting evidence. We will review these guidelines briefly here. First off, empiric antibiotics should be initiated within 1 hour of recognition of sepsis, after cultures have been taken from the blood and other suspected sites of infection. Patient mortality rates due to sepsis increase by 7% for each hour antibiotics are delayed. Initial empiric antibiotic therapy should be broad, with activity against all probable pathogens. Identify the possible source of the patient's sepsis and control it with antibiotics or removing the source, for instance, removing an infected line or draining an abscess. Obtaining cultures, initiating fluid resuscitation, and giving antibiotics should be occurring within the first 30 minutes of recognizing sepsis, and the entire care team needs to understand the urgency of treating these patients. Resuscitation begins with a goal of maintaining adequate tissue perfusion. Most patients need 4 to 6 liters of intravascular volume replacement within the first 6 hours. When starting fluid replacement, give a 1 liter bolus minimum and keep the fluids going until there's a central line in place to monitor their central venous pressure, or their oxygen requirements are going up and they may be in pulmonary edema. Give fluids until their central venous pressure is 8 to 12, which correlates roughly with a JVP of 4 centimeters. Studies have shown that crystalloid solutions such as normal saline and colloid solutions like albumin have similar outcomes, so often the initial fluid of choice for resuscitation will be normal saline. You want to target a mean arterial pressure of 65 millimeters of mercury, as this reflects the pressure that the tissues are seeing. When fluid challenge fails to restore adequate tissue perfusion, vasopressor therapy may be necessary. A central venous catheter is needed to infuse vasopressors. You can monitor whether there is adequate tissue perfusion with some objective measures. The urine output, suggesting good renal perfusion, should be at least 0.5 to 1 cc per kilogram per hour. Serial assessments of lactate can help determine tissue perfusion. Some additional therapies have shown benefit in patients with severe sepsis or septic shock. These are mostly administered in an ICU setting but are worth knowing about. Protein C can help inhibit thrombin formation and enhance fibrinolysis of microthrombi, and has shown a highly significant mortality benefit in patients with severe sepsis at high risk of death. Replacement dose hydrocortisone use is controversial in patients with shock, but there may be benefit in patients that are hypotensive despite adequate fluids and vasopressor use. Hyperglycemia can impair antimicrobial defense mechanisms and worsen the coagulopathy of sepsis. The NICE sugar study suggests improved mortality and less adverse events were seen with a conservative blood sugar level of less than 10 millimoles per liter. These levels are targeted with insulin infusions and monitoring. Transfusion strategy should be conservative. The TRIC trial found conservative hemoglobin levels between 70 and 90 grams per liter as adequate for most patients, and some patients with severe sepsis will require mechanical ventilation. Call a senior medical resident if you notice 2 or more SIRS criteria are present in a patient, as this may indicate the patient is septic, and early management will be important to improve the patient's chance of survival. In summary, sepsis is diagnosed when there is known or suspected infection along with 2 or more SIRS criteria present. Obtaining cultures, initiating fluid resuscitation, and giving antibiotics should be occurring within the first 30 minutes of recognizing sepsis. Mortality increases dramatically as antibiotic administration is delayed. These patients need frequent reassessment and may need a step-down or ICU bed to facilitate this. You can monitor parameters such as blood pressure, urine output, mentation, and serum lactate to assess response to therapy. Do not forget to identify and control the patient's source of sepsis.